It is on behalf of my fellow investigators and the corporate sponsor, it is really my privilege to share the one-year outcomes of the early feasibility trial for this novel AATS pulmonary valve. Neither myself or any of the co-authors have any relevant financial disclosures. As this audience knows, the burden of pulmonary valve disease in our pediatric patients is real, lifelong, and impactful. Unfortunately, there is no good solution, a significant technology gap. We have no specifically designed pediatric pulmonary valves. There's no FDA-approved pulmonary valves. Most of us use off-label adult valves or homographs. All of our options have significant limited durability, either because of somatic outgrowth of the patient or, importantly, failure of the leaflets due to primarily calcification, such that in the pediatric population, any of these bioprosthetic valves last no more than 5 years. The younger you are, the less durable, and it's primarily related to leaflet function. The advancements in the field are primarily adult transcatheter pulmonary valves that, again, are not suited for our pediatric population. Because of this technology gap, we shift the burden to our pediatric patients to have suboptimal valve function with potentially lifelong impact on their ventricle, impacting their quality and quantity of life. In this context, it was very exciting that potentially a solution existed in our own body. The human femoral valve has some unique elements. First of all, it has a very long area of coaptation. It's a bileaflet valve. This allows the valve to expand and maintain coaptation through a wide range of diameters. Also importantly, there is a very vigorous vortex of flow within this sinus that resists thromboembolic phenomenon. So the goal was to create a mimic of this natural valve with two primary focuses, one that would allow growth in the growing child and improve leaflet durability through material usage as well as flow dynamics. That birthed the AATS pulmonary valve that, as it is expanded with standard balloons, it shortens and allows an increased orifice without stretching the material or compromising the material. Some elements of the valve that are important, again, it's this bileaflet structure. It can be dilated from its nominal size of nearly 12.5 millimeters internal diameter all the way up to 22. It is fully synthetic. The stent is from stainless steel, cut from a single tube. The outer sleeve, which is the sewing cuff, is from a standard EPTFE stretchable. The leaflets, importantly, are from the thin 0.1 millimeter EPTFE that has a now well over decade experience both in Japan, in the US, and elsewhere, with very good durability and really no incidence of thromboembolic phenomenon or endocarditis. As mentioned, this can be balloon expanded in a transcatheter fashion to match somatic growth, and it is implanted in a standard surgical fashion. The early feasibility study design was that of an FDA-approved, prospective, single-arm, multi-center, IDE-based study to enroll up to 15 patients at 5 centers. In fact, it utilized only 3 centers, with the objective of all EFS to evaluate safety and preliminary effectiveness in patients 1.5 years of age to 16 years of age. Oversight included a eligibility screening committee for any patient enrolled, and then independent safety monitoring and clinical event committees with independent pediatric surgeons and cardiologists, and then an independent echo core lab. Study follow-up included baseline, discharge, 30 days, 6 months, 1 year. I'm going to report the 1-year outcomes, but these patients are being followed for 5 years. Important inclusion criteria was the age of 18 months or 1.5 years, all the way till 16 years of age. Importantly, these were native right ventricular outflow tracts. These were not patients who had a previous conduit. They need to have met indication for pulmonary valve replacement based on echocardiographic findings and a consensus within the center's case management conference as well as the screening committee, and then have a body habitus that allowed the size of the graft to be implanted. Important exclusion criteria were pretty typical. Abnormal pulmonary vascular bed, either by number of vessels as well as pressure, an inability to have the necessary antiplatelet drugs, or could not be used in acute endocarditis. The primary endpoints again reflect an early feasibility study, with primary safety endpoint being a composite of freedom from device-related important clinical events such as death, valve thrombosis, or thromboembolism. The primary effectiveness endpoint was a clinically acceptable hemodynamic performance at 1 year, which was essentially normal pulmonary valve function with less than moderate pulmonary insufficiency. This represents the typical intraoperative. We would use a study nomogram of normal pulmonary valve function, graph the patient's body surface area, and target a valve size between -1 and +1, giving us an internal diameter of the AATS valve, which would, on a side table at the time of surgery, be balloon dilated with a standard commercially available balloon to the appropriate size, and then sewn in a typical fashion on bypass. This is the proximal part of this outer sleeve being sewn with the distal end tucked into the main pulmonary artery in this example. The baseline characteristics of the 11 patients that were implanted at 3 participating centers. 9 of the 11 were boys. The age range was a little more than 2 years of age to just under 14 years of age. The majority had tetralogy of Fallot with a prior transannular patch, and the indication for surgery in 10 out of the 11 was severe pulmonary insufficiency, but 3 had concomitant pulmonary stenosis. The list of procedural details of note: the implants ranged from 14 internal diameter to 20. Again, the ages was from 2 to 16. Importantly, the concomitant procedures were primarily those related to either the branch pulmonary arteries or the infundibular stenosis, although there were 2 patients who had concomitant either mitral or tricuspid valve repairs, all of which were done prior to the implant of the AATS valve. All patients enjoyed acute procedural success, meaning no pulmonary insufficiency and no important pulmonary stenosis. And all patients, again, reflected that this was a standard, typical pulmonary valve replacement with an expected very short hospital stay. In terms of outcomes, the 1-year safety outcomes showed complete freedom from any important adverse events. There were no events that met study criterion for primary or secondary safety endpoints. There was 100% freedom from death or device-related interventions. There was no device-related or unanticipated adverse events, and there were no major protocol violations. In terms of effectiveness outcomes by echocardiogram, you can see the pre-AATS implant showed severe pulmonary insufficiency in the majority of patients. Immediately post, there was no pulmonary insufficiency, and this remained durable to 1 year. In terms of remodeling of the right ventricle, although these are echocardiographic findings, they show a nice trend of improving favorable remodeling of the right ventricle because of the absence of stenosis or insufficiency, with essentially no pulmonary stenosis over this 1 year duration. Quality of life was excellent. Those patients that had exertion with, had dyspnea with exertion enjoy no symptoms and are completely asymptomatic in all patients at 1 year. In conclusion, this FDA-approved prospective trial showed all subjects were alive and clinically well at 1 year follow-up. There were no device-related adverse events, including no thrombosis or infectious complications. All subjects demonstrated significantly improved hemodynamic performance and reduced right ventricular volumes compared to their baseline, and all subjects demonstrated intact device function with no important pulmonary insufficiency or stenosis at 1 year follow-up. Because of these data, the FDA has approved the trial to move into a expanded multi-center IDE pivotal-based trial to enroll up to 50 patients. Thank you.